Hi, I'm Tim Lovell, and I want to talk to you all about your upcoming knee replacement surgery. I want to tell you all about what we're going to do. I want to tell you about potential risks and complications, and then I'm going to come back in, answer all your questions, and we will do our consent form for surgery. First, I would encourage you to have a spinal for anesthesia. That's where they numb you up from the waist down. Now, they will also give you medicine through your IV so you sleep the whole time. But if anesthesia says it's okay for you to have a spinal, I would encourage you to have a spinal. Once you're comfortable, we make an incision on the front of your knee, and we go into the knee without going through or across any muscles or tendons. We pull them out of the way. We also use computer navigation to help us get the parts lined up right. So you will also have two little nicks about in the middle of your shin, and we put two temporary pins into the tibia or leg bone. And through the main incision, we put two temporary pins in the femur or thigh bone. That allows us to use a computer to help get everything lined up just right. Now, when people hear a total knee replacement, I think they think that we take out 6 inches of the knee. We don't. We are truly just resurfacing the ends of the bones. We only take out about 1/4 inch, maybe a little bit more, off of the ends of the bones. And we resurface your knee with metal and plastic. So in a total knee replacement, there will be a piece of metal on top of and into the tibia or the leg bone, and a piece of plastic goes into that. There will also be a piece of metal on the end of the femur thigh bone, so you have metal rubbing on plastic. We also put a piece of plastic behind your kneecap. So the kneecap that you feel underneath your skin will still be you. Underneath that goes a piece of plastic. The parts are made of metal and plastic. They're held in place with bone cement. Once the parts are in there, we close you up. You go to the recovery room for a couple of hours, and you go up to your room on the floor, and we'll get you up walking that same day or the next day. You're typically in the hospital for 1 to 3 days. So for example, if your surgery is on a Tuesday, we would let you go home Wednesday, Thursday, or Friday. I don't care so much when you go home, I care that you're safe to go home. And that means that you and the nurses and therapists all agree that you're safe and ready to go home. I don't care if it's 1, 2, or 3 days after surgery. Having said that, we do try to get you out of the hospital as quick as we can to get you away from all the resistant bacteria that live in the hospital. So honestly, if you're ready to go home the day after surgery, we're happy to have you go home the day after surgery. And it's not because we're trying to be mean and kick you out of the hospital. We want to get you away from all those resistant bacteria that live in the hospital. But we will not let you go home unless everybody thinks that you're safe and ready to go. Now initially we're going to get you up walking with crutches or a walker, and doesn't matter to me if it's crutches or a walker. I let you and the therapist decide that, but you can put all the weight you want on your leg immediately. We still have you protect it with crutches or a walker, but you can put all the weight you want on it immediately. When you go home, whenever you feel comfortable, you can get rid of the crutches or a walker and go to a cane. We then have you use the cane until you can walk without a limp. And the reason is if you're limping, it puts more stress on the parts. So if you're limping, I really would prefer if you use a cane. Now, for you to get as good as you're going to get after a knee replacement is honestly 2 to 3 years. There's actually a study that shows it takes 3 years to get as good as you're going to get after a knee replacement. Now, most of the getting better is in the first 6 months. In fact, I let people play golf in 3 months. But you will feel better 2 years from now than 1 year from now. Anytime you have surgery, there are risks. And I'm going to tell you these things not to make you nervous. It's just so you know what's going on. Anytime you have surgery, there's bleeding, and you could need a transfusion. It's possible. Anytime you have surgery, there's a risk of infection. We're going to give you antibiotics through your IV just before we start surgery and for the next day, and that helps decrease the risk of infection. Nationwide, it's considered just under 2% unless you're diabetic, and then it's about 4% risk of infection. Now, if you were to get an infection, if it happens in the first few weeks after surgery, it sometimes can mean another surgery to wash it out and up to 6 weeks of IV antibiotics. And sometimes that will take care of it. If it did not take care of it, or if you were to get an infection a few years from now, then it's typically a minimum of 2 surgeries to get rid of the infection. The first surgery, we have to go in and take out all the parts and thoroughly wash and clean out the knee. Then we would put in a temporary knee replacement using bone cement that was just packed full of antibiotics. The idea is that the antibiotics would then leak out of the bone cement to give very high levels of antibiotics in the knee joint. You then would get 6 weeks of IV antibiotics, and 3 or 4 months from the takeout surgery, we come back, and if the infection's all gone, then we can put final parts back in. Big deal if you get an infection. Anytime after this you have dental work done, even a routine cleaning at the dentist, we would like you to take antibiotics by mouth an hour ahead of time, and that's for the rest of your life. And you can either call your dentist's office or our office, and we will call them into the antibiotics into your pharmacy. Anytime you have surgery, there is a risk of damage to blood vessels or nerves. And I'm working right on top of all the big ones behind your knee. We know that. And we are paranoid about protecting them. And the risk of injury to the big blood vessels or nerves is less than 1%. Now, all of us have these little skin nerves that come down your leg and cross over like this that are so small I can't see them. And whenever we make the incision for a knee replacement, those little skin nerves always get cut. So your skin will be permanently numb on the outside of your knee. Anytime you have knee surgery, there is a risk of getting blood clots in the veins of the legs. We take those very seriously because rarely they can break off and go to the heart of the lungs, and extremely rarely people have actually died from that. So we do everything we can to prevent blood clots. We're going to put you on a blood thinner after surgery. We're going to put these lovely white TED hose on your lower legs. While you're in the hospital, we put these squeezers on your calves that help pump the blood up. As soon as you wake up, I want you to start moving your feet up and down, just like this. And that's the other reason we're going to get you up walking right away, because all of those things help prevent blood clots. Anytime any of us have surgery, scar tissue forms, because that's how all of us human beings heal. That scar tissue would just love it if you would go home and sit in your recliner and do nothing, because then it wouldn't hurt so much. The problem is that scar tissue eventually sets, just like concrete sets. And if you were to go home and just sit in your recliner and do nothing, your knee would eventually get stuck in one position. This is where surgery truly is a team effort, and you are the most important player on the team. And I'm going to give you the ball as soon as surgery's over. How much motion you have in your knee a year from now is going to be more up to you than it is up to me. I will not leave the operating room unless your knee goes perfectly straight and bends all the way. Then I know the parts can do what they need to do. How much motion you have a year from now is up to you, and how hard you work on it. Now, we're going to help you with that. When you go home, I want you working with a physical therapist, ideally 3 days a week. But I want you yourself working on it at least 3 times a day. The surgery is actually the easy part. I get the easy job. The hard part is the rehab afterwards, and that is completely up to you. And we will show you exactly what we want you to do. Now, whenever we put anything artificial in the body, one of 2 things has to happen. Either the parts are going to outlast you, or you're going to outlast the parts. What we all want is for the parts to outlast you. The problem is they're just artificial parts, and it is possible that they can wear out or come loose from where they attach to the bone. And if that happens, we just go back and redo them. Anytime you have surgery, there is a risk of heart attack, stroke, pneumonia, bladder infection, things like that. Anytime we do a knee replacement, not 100% of people will love it. So there is a chance that you may not love your knee replacement. It's not a high percentage, but there is a percentage of people who don't like their knee replacement as well as they had hoped it would turn out. The last thing is, even if everything goes perfect, nothing I do can make you like you were when you were 16. I'm going to come in a few minutes and answer all the questions you have, and we will do our consent form. This is not the last call for questions, though. When you go home, if you think of any questions, write them down and bring that list with you to the hospital, because I am going to see you in the hospital before the surgery. And I don't care if you come in with 10 pages of questions. I will go through every single question before we do the surgery. Thank you.